Today's CME is on blood pressure targets in ICU. Can we decide it at the bedside? So I'll start with audience question. Why might a patient with a normal blood pressure still require interventions to improve perfusion? A. Blood pressure is an unreliable indicator of perfusion status. B. Hypoperfusion can be present due to inadequate cardiac output or increased vascular resistance. C. Normal blood pressure guarantees adequate oxygen delivery. And D. All critically ill patients require vasopressor regardless of perfusion. So, the answer to this question is hypoperfusion can be present due to inadequate cardiac output or increased vascular resistance. Meaning, it's not the blood pressure that needs care, but we need to think beyond. So, my presentation flow would be, I'll de-emphasize MAP and emphasize on perfusion pressure. I'll talk about MAP and the organ damage associated with the targeted MAP. I'll show you some evidences relating to vasodilatory shock, perioperative period, cardiac critical care, traumatic brain injury, and cardiac arrest. And then how to go about at the bedside and decide MAP for a patient with a take-home message. As we know, perfusion pressure is MAP minus central venous pressure. So if you want to know perfusion pressure of an organ, for example, cerebral perfusion pressure, it is MAP minus ICP, renal perfusion pressure, MAP minus renal venous pressure. But coronary perfusion pressure, the driving pressure is not MAP, but diastolic blood pressure, because coronary fills in diastole. So now, we know that blood pressure is a product of cardiac output and systemic vascular resistance. Cardiac output is flow and systemic vascular resistance in terms of pressure. So when we say blood pressure target, it is a product of cardiac output and systemic vascular resistance. Meaning, if you have high systemic vascular resistance, MAP would automatically be high. And that happens in a patient who is in compensated shock. Compensated shock patients usually have high systemic vascular resistance and low cardiac output. But when we are measuring blood pressure, it is normal. So there we may fail if we target blood pressure rather than looking at the flow aspect of it as well. So it's so essential to follow perfusion pressure. Several evidences from the journals which are very recent, and what they have done is they have compared low target versus high MAP target. So I'll be putting all the papers, they'll be in a format where they have compared low MAP target versus MAP target, a high MAP target, and see the outcomes. So for example, what is BP target? BP target, when they are studied in all the research paper, it means it shouldn't be in that range, rather it triggers vasopressor use with that pressure. For example, if I have a clinical trial where the two MAP targets are compared 50 versus 65, then 50 persons I'll be following that map for each patient, and the group of 50 map. If the pressure is going down to 49 map, then only I'll start vasopressor. It is the trigger of vasopressor rather the maintenance in above 50. So it means that this makes you clear when I have put up all the papers which are done on comparing lower and higher map targets. So it is nothing to do with the maintenance in the range, rather it is the vasopressor trigger, the pressures which are compared. With this knowledge, I'll move on to physiology. As we know that in all shock, our body responds in only a few ways, that is through catecholamine or vasopressin or renin-angiotensin aldosterone system. So these are the main trigger agents in shock which happens in human body. We know it. Word about autoregulation. Since this was the paper published in Physiology Journal in 1959, which was the first of its kind. The chief investigator Larson has first time in the world shown to world that if you maintain a mean arterial pressure between 60 to 150, there will be no increase in the blood flow to brain. This is static. So autoregulatory curve is maintained between the map of 60 to 150. After this, many of the other organs' regulatory systems were studied and they were found to be in the same range. So now we know that bodies or organ systems regulatory blood pressure is between 60 to 150. If your pressures are less than 60, then the blood flow is drastically low, and if the pressures are more than 150, the blood flow is drastically high. So we need to be in the range. Is there any relationship between BP, blood pressure, and organ damage? I'll put up some of the papers which have shown yes, there are. This is from Intensive Care Medicine Journal of 2024, last year. It's a meta-analysis which looked into shock state and mortality and morbidity, and it included about 13 studies, and the results, as you could make out, is favoring hypotension, meaning even if you are low on pressure, it is no different from the people who are high on pressure. Meaning we shouldn't target higher MAP because it is not giving you more benefits. The same paper which have included perioperative period group of patients, and they found the same. There is no difference between low pressure and high pressure groups. So it's a recent study accumulating all the prior randomized control trial, observational studies, retrospective study. So 2024, we came to know that even if the pressures are low, it is no different than the pressures when we are keeping it high. But this was a paper by Jin Liu Vincent, where this was a database from Mimic from Boston, America, and what they tried to look at is retrospective analyzing the data, and where they found they can quantify the deaths with the pressure. If your pressure is less than, MAP is less than 75 for 2 hours, then the probability of mortality is increasing by about 2%. That means even if you are MAP maintained for 2 hours, then the probability is 2% more than the MAP when it is higher. So this is saying something different. but it is an observational study from a retrospect data. So the weightage on evidence base is pretty low. Then we move on to this article, which was from Volume Challengers group, looked into septic shock patients and quantify with the use of vasopressor in a dose about 10 microgram per kg per minute increase. If you increase a vasopressor dose 10 microgram per kg per minute, then the mortality, 30-day mortality is increasing. Meaning, if you are targeting a high MAP with vasopressor, you'll be getting negative results in your patients. So, this is in septic shock. Now I'll put up papers, all respective papers in a different subset of group. For first is vasodilatory shock, which is sepsis. So the first paper, which is a landmark study by Afsar, comparing high versus low targets, have shown that it is of no difference. Mortality is same, either you follow the higher group or the lower group, meaning lower group can be as useful as high. This was the landmark study in 2014. In that same study, the subset of patients who are benefited with higher blood pressure were patients who are chronically hypertensive, and the advantage they got is they have to go renal replacement therapy lesser than the low target group. Then the same database, the same study, post hoc sepsis PAM trial, the post hoc data was analyzed for another feature, that is for delirium and arousability, and what they found is high pressure targets have lesser delirium. Meaning, if subset of patient in septic shock, if your patient is going into delirium, particularly that time you can increase your pressure target to higher targets. This was a paper published in JAMA in 2019. It's a similar study on septic shock, and the age group they took is 65 and above. So this is famously known as 65 plus trial, where Lamotan has shown that there is no difference in mortality at 90 days. Either you target low or high. So then we look at this article from Khanna and group, where they have quantified from a retrospect data analysis of electronic medical record of about 80,000 patients from America, Cleveland Clinic, and where they quantify that what pressure and below what, if you do not keep at least this, mortality or the other morbidity would be more. And they could quantify it with MAP of less than 69, SBP less than 100, diastolic blood pressure less than 60, and pulse pressure less than 57. So if you are below these targets, the probability of harm is more. So you need to at least maintain these targets. And they show that all the pressures can be taken as equal. Then this meta-analysis from Richard Belle, which was published in Critical Care Medicine in 23, have took Afsar and Lamotan trial included, and what they have shown in systematic review is there is no significance again. And above all, in the concluding remarks, they showed that there is moderate certainty evidence from 3 randomized trials which showed that lower vasopressor exposure probably is benefiting patient and decreasing the mortality. So it is not the target of the pressure, but it is the vasopressor in itself which becomes the determinant of mortality. Moving on, We have another systematic review and meta-analysis which was published last year, 24, by Amico. The beauty of this systematic trial was it included only RCT, no other observation or retrospect data. And because it included RCT only, the authenticity of the data is good. And what they could find out with the forest plot, as you could see, that permissive hypotension is doing better. The pressure is low and the patients are living more. This is the last of the systematic review done, and it included only RCT. So the weightage to this would go high up. So I could conclude that in vasodilatory shock, at least, target should be low, and rather it should be personalized rather than one size fits all approach. Moving on to perioperative period where patients are being operated, I have few database to show. One of them is a trial by Kamal Maheshwari group from Cleveland Clinic, Ohio. And this is a retrospect cohort analysis in post-operative critically ill. And what they could make out is, if you have perioperative hypotension, be it intra-op, be it post-op, they all are in a way trigger for delirium. So they could show that if your time weighted average of MAP less than 65, then you could make out its a hazard ratio is 1.11 for delirium. And the same patient who has underwent surgery and now in ICU has gone into hypotension, then the MAP targeting should be a bit higher, because what they have shown is a MAP of 83 patients are going into delirium and MAP of 86 patients are not going into delirium. It's a so small range. So probably because of being a retrospective in nature, this might not help, but may need further study to conclude whether it is actually this or not. Then I have the same Filippo Amico paper, the last of the systematic review, and the subset of patients was surgical patients, and they tried to look at whether lower pressure is helping or not, though the indication is toward the lesser, but it is insignificant. Maybe the future study will tell where we are. So in perioperative critical care, it is probably again personalized rather than. Now moving on to cardiac critical care. Subset of patients who are in cardiac CCU or they are going for surgeries. The evidences are, this was Jacob Jenger study, who was the first to say that isolated hypoperfusion is equal killer to isolated hypotension. So it is not only hypotension. If you have normotension but less perfusion, they are equally bad. Paper published in 2020. So hypoperfusion is equal to hypotension. Next audience question would be, which of the following intervention is best suited for a patient with signs of hypoperfusion despite a normal MAP? The MAP is normal. So which of the following is best? Increasing vasopressor dose indiscriminately, fluid resuscitation, improving cardiac output and addressing oxygen delivery, lowering MAP to reduce cardiac afterload, or monitoring without intervention until blood pressure drops. So what will you do? So it is B. So it is not only MAP, it may be normal, it may be compensated shock. So you need to resuscitate basis the hypoperfusion. The focus would be on hypoperfusion. If you have APG, it will tell a lactate of more than 1. Now this is Ashish Khanna's review paper from Debeki Methodist. And in cardiac critical care, what the paper suggests is the goal map should be individualized, basis, age, nature of surgery, intraoperative course, if you have left ventricular versus right ventricular dysfunction in the patient group, or there is presence or absence of mechanically circulatory device, which are quite in use in cardiac critical care. So it is not a single map, rather it should be individualized or personalized. He suggested a group of patients who should be on the higher map targeting, and they are right ventricular failure, RV dysfunction, hemodynamically unstable on weaning from CPB, air in the coronary arteries post cardiac surgery, patients with long CPB time and cross clamp time, AKI basis urine output parameter, intra-op, HOCM or LVH, and history of chronic hypertension. So these are high map targets for particularly cardiac critical care. There are also low map targets where low pressures should be targeted, and they are these patients with LV dysfunction where reduction in afterload will help increase output, such as regurgitant valvular lesions, or you have a mechanical circulatory device where your target should be lesser pressure rather than high. So it is again cardiac critical care. Again, this is the review inclusive of all latest review from Cochrane, which say the higher blood pressure target make little or no difference to any outcomes you could see. So it is including all AKI. So it should be again individualized rather than high targets, which we tend to do often. What about traumatic brain injury, a patient with trauma? So as we know, Brain Trauma Foundation guidelines suggest SBP of more than 100 or above 110 in particular subset of patients to keep a CPP of 60 to 70 with an ICP less than 20 is the target. So only one study from Brain Trauma Foundation is a guideline. At least a systolic of 100 or more than 100 for a subset. What about cardiac arrest patients? A paper in NEJM has been published which showed patients who have underwent arrest out of hospital, they were brought to hospital after resuscitation, and again low and high targets were compared, and they found that there is no difference in either of the group, no mortality benefits with either of the pressures. So cumulatively, if you look, every time the summary remains the same, that it is not the target pressure, rather the personalization to each subset of patients. So this is cumulatively what we could make out. All the trials which I have put forward is same. Now, how to go about at the bedside? What should we do at bedside to personalize it? So this is a paper from John Liu Vincent. So as we look at the history of critical care, we started from goal-directed therapy, where goals were fixed, and then we tried to achieve the goals, and then we are doing nothing. Earlier, it showed some benefit, but later on, it showed that there is no benefit of achieving the goals and fixed goals. The goals should be individualized. Then comes individualized hemodynamic therapy, where we are using all the dynamic parameters and then trying to give fluid and achieve good cardiac output without using a vasopressor. So the final target should be personalized hemodynamic target, where a person's baseline blood pressure should be valued and If you do not have the person's baseline, particularly at that time, the adaptive multi-parametric approach should be followed, where you see the patient, see the output, see the pressure. If the output is not coming in 4 hours, then increase the target gradually. That should be personalized. How you do it in modern day critical care is through use of dynamic tools like this, either invasive, minimally invasive, or non-invasive. So with that, I'll come to take home message. It's very clear. Though arterial blood pressure is often a surrogate for tissue perfusion, but it poorly reflects actual blood flow. Blood pressure should be assessed alongside blood flow and metabolic indicators. An intensivist must adopt personalized blood pressure target based on patient characteristics. With that, I'll end. Thank you very much.